Welcome everyone. My name is Elena Kidd and I'm a program director in the University of Alabama at Birmingham School of Public Health. I'm very excited to welcome you today to the webinar, Understanding Models to Predict Viral Spread and Community Impact, featuring Dr. Suzanne Judd. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance Center, or ARC IPC. The ARC IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreak Division and the University of Alabama at Birmingham. The ARC IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view past trainings and podcasts, training and technical assistance, and view infection prevention and control resources at go.uab.edu/ARCIPC or email arcipc@uab.edu with any questions. You can also sign up for the ARC IPC Newsletter to get updates on upcoming training and events through the link on the screen and the QR code. We would also like to thank our co-sponsors, the Office of Public Health Practice, the Public Health Student Association, and the Deep South Center for Occupational Health and Safety. Each co-sponsor is offering virtual events throughout the semester. Be sure to check out their website and social media for updates. We'd also like to let you know about another upcoming webinar, Prevention and Mitigation Strategies Through COVID-19 Pandemic, a Local Public Health Official's Perspective, with Dr. Mark Wilson. Jefferson County Health Officer Mark Wilson will review and discuss prevention and mitigation strategies employed or not employed from the beginning of the COVID-19 pandemic until now, and some of the challenges he and the health department faced. Please join us for this webinar on October 13th from 12 to 1 p.m. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, complete the evaluation following the program, and upon completing the evaluation, complete the Alabama Nursing CEU request form. You will be redirected to this form upon completing the evaluation. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. CEU units for this program will expire on 9/29/2022. If you experience any issues, please email arcipc@uab.edu. I would now like to introduce our speaker. Dr. Suzanne Judd is an investigator with the ARC IPC. She is also the director of the Lister Hill Center for Health Policy and a professor at the School of Public Health at UAB. She received her PhD in Nutrition Sciences from Emory University, where she led 2 vitamin D clinical trials. Dr. Judd is multiple principal investigator on both the REGARDS and rural cohort studies, which are large NIH-funded epidemiological cohort studies seeking to understand disparities in chronic disease in the US. Her experience in the US has provided a platform to collaborate with European cohort studies in France through the Fulbright Scholars Program. Her unique combination of training in engineering, epidemiology, and nutrition, as well as industrial experience, have provided a solid foundation to guide her research, mentorship, and collaboration in public health communication. So without further ado, I would like to turn this webinar over to Dr. Judd.
I'm really excited to be here and chat with you all a little bit about some of these infectious disease models and how we use them, try to demystify them a little bit for those of you that have been following models. We're going to start with COVID, but we'll apply it to other infectious diseases as well. And kind of just taking a step back, let's just talk about monitoring infectious diseases. So when we monitor infectious diseases, the word epidemiology, a lot of people don't think about it. In fact, some people I found even before COVID didn't really know what epidemiology was. Well, it literally means upon the people. It's those things that happen to the people. And for years, millennia, infectious diseases have been around. Historically, cities were considered the hotbeds for infection. That was where people thought that infectious diseases kind of lived and congregated. It was considered less safe to be in a crowded area than it was a less crowded area. So there were lots of practices that people had, including leaving the city to get away from it, using measures like quarantine, where you might separate someone who was known to be exposed to a various infectious disease from the population. Also, isolation. You've heard about this with COVID. Isolation is a little bit different than quarantine. In quarantine, you're removing healthy people that could become infectious, but in isolation, you're removing people that are already infectious and known to have the disease. There are many famous historical outbreaks that some of you have probably heard about. Influenza from 1918 around World War I is the one that people talk about the most right now. But the plague is another one that is commonly referred to, especially if you read a lot of historical literature. It was around the 1300s. The HIV in the latter part of the 1980s, 70s, 90s, that's actually why I'm an epidemiologist, was my following of the HIV epidemic. And now this year we've got COVID-19, which is really the last 18 months. COVID-19 was not the first coronavirus that was considered to be particularly lethal. We had the SARS in 2005 and MERS after that. I always like to put a slide like this up. How do you catch COVID? If you talk to people in the lay population, we here epidemiology, we talk about transmission and transmission controls and mitigation, but you talk to the public and they talk about catching COVID. So I think it's important whenever you're talking about any infectious disease that you're aware that we know how it's spread and we can talk to people about that. In the case of COVID, it's a respiratory infection. So it's going to come when you're in contact with someone's respiratory droplets, either direct contact because you're very close to one another, perhaps you're eating together and some of those droplets make it onto food that then goes into your body, but it has to go from that person to you. So you have to be in relatively close proximity. Although it can be in the air, it doesn't live airborne, like something, say Legionnaires would be something else that would really be airborne and have the potential to stay in the air for a while. The virus for COVID does leave the body and can stick on surfaces, although it doesn't live long on those surfaces. What kind of tools do we have for this particular virus? I think you're going to hear a lot more about those tools from Mark Wilson in a couple of weeks. It sounds like that'll be a great talk. But what we typically do with COVID or any infectious disease is to monitor symptoms. We can start with the symptoms to see if someone becomes symptomatic. We can ask people about their symptoms, encourage people that are symptomatic to stay home, and that can help to reduce the spread. We can also monitor cases by doing regular testing to make sure that the folks that are in social situations are free from COVID and less likely to spread it. We can look for severity. It's one of the big things we do with infectious diseases. I think that people didn't realize prior to COVID that that's actually what the health department and epidemiologists have been doing for at least 150 years. They're looking at various viruses and bacteria and other pathogens like parasites to see, we know it's at a normal rate in the population, but when does that rate go above the normal rate? And when is it alarming? Things like deaths and hospitalizations would make a particular virus alarming. And then we can have these policies that will help us to reduce transmission. These policies are not going to be the same for every virus, bacteria, parasite. We might use different policies to combat, say, a parasite that's in the water. We have policies for chlorination of the water and ensuring regular water testing. But in the case of COVID, social distancing and masking were policies that really helped us to reduce transmission. With COVID, we also know that the event size mattered because the size of the event would increase the likelihood that a person might come in contact with someone that's infectious. With some infectious diseases, you don't have to worry about that. You can get together in a large gathering, even though say a basic coronavirus or a basic respiratory virus were circulating. You could have a football game or a concert and it wouldn't be that big of a deal because some portion of the population has immunity to the virus or the bacteria. In the case of SARS-CoV-2, it was a novel coronavirus that no one had immunity to. So it could race through the population quite quickly. This slide just shows you how the size of the event matters, that events as large as 100 really need very low circulating levels of COVID in the community. Across the bottom, we have the number of cases per day per 100,000, 33, 13, and 4.5. And you can see that it really makes a difference, that circulating level of cases, that baseline rate of cases in the community, that really makes a difference in terms of how much risk there is that someone could come in contact with someone who was infectious for COVID. The other big factor across these 4 bars is that as the size of the event gets bigger and bigger and bigger, the more likely it is that someone could come in contact with somebody who is infectious with COVID. Again, talking about transmission, this is really important for whichever virus or bacteria you're thinking about. But with COVID, we know that there are several factors that can increase the likelihood that if someone were infectious, they could spread it to someone else. That high occupancy that we just saw, it matters what the size of the gathering is. It matters how much the air is turning over. So if you're inside versus outside and how that air is turning over. It matters how aggressively you're able to spread your respiratory droplets. So singing and shouting would be something that would be more likely to spread respiratory droplets, as would coughing and sneezing. Those would be in folks that are symptomatic. Face coverings are the other big factor. So covering the face to keep those droplets from going to someone else is something that really helps to reduce it. Well, as we've talked about spread, the reason it matters is because how the disease is spread impacts how you'll model the disease. So you might model the disease differently if a disease is waterborne versus it being spread by respiratory droplets like COVID. The model itself really does help policymakers to keep the population safe. It helps us to develop various strategies that will reduce transmission. And it's not going to be the same for every virus. When you've got something like COVID that's respiratory borne, that's why the mask mattered. But if you have a sexually transmitted disease, you're going to use other measures like condoms to increase the likelihood that it will not spread from one person to the next. So decrease the spread. Information to the hospitals to plan for excess capacity. That's what we saw with COVID. Again, not every virus or bacteria, every pathogen is going to require communication with the hospitals. But in the case of COVID, we really had to carefully coordinate with hospitals so that they would know if they were going to need to have excess capacity. It's important to have these models so we can project for manufacturers to better predict what kind of supply needs there are. This is not just about facial masks and glasses and gowns and things the hospital folks need, but these are things like reagents as well. Things like bleach, if people are going out to buy more cleaning products. It's really important for us to be able to tell these manufacturers what's happening so that they can adequately predict what kind of supply chain issues they might have. The other thing that it helps us to do is to give us a common language. I think that we learned in this pandemic that epidemiology language, it might be common to epidemiologists, but it's not common to everyone. So the model helps us to create a language. The words flatten the curve was something that came out early in the pandemic. It also will give us some metrics so that we can know whether or not what we do is successful. One of the things that you may have found frustrating with COVID is that there were so many different epidemic models and no one seemed to accurately be able to predict where it would strike next and how severe it would strike. That's because there are just a lot of factors that go into these models. There are things like people's behaviors that may change over time that can affect the model, and assumptions will change too, especially if you have a brand new virus like we did with SARS-CoV-2. So what are our strategies? This is, again, kind of taking you back to the vocabulary of epidemiology. We have a couple of different strategies that we can use with infectious diseases. One of them is to suppress it altogether. And obviously, we would love to suppress every infectious disease and keep people healthy and free from infectious diseases. That's not always possible. Obviously, there are circulating infectious diseases that we call endemic, which endemic just means that there is a baseline rate of disease and that disease is always there. Endemic does not mean that the disease is safe. It just means that there is a predictable baseline rate of disease. Mitigation is what we're going through with COVID right now and what we go through with several other infectious diseases like the flu, like influenza, like rotavirus, which is a common GI bug that makes people have like stomach issues, nausea, diarrhea, things like that. In the case of those viruses where we know we can't suppress them altogether, or eradicate is another word that we often use. If we can't eradicate it, then we try to mitigate it. We try to lessen the severity of the burden. Another virus that you can think about that we do a lot of mitigation effort for is hepatitis. Hepatitis is a common virus. It can contaminate food, and we regularly have to ensure that our food supply is safe. We have to look for symptoms of hepatitis, gets reported to the health department, and then try to contain it if we find that there are hepatitis A outbreaks. So mitigation is probably more common than what we think of than suppression. With suppression, really vaccinations are our best effort to suppress various viruses. We've done a great job suppressing, for example, smallpox to the point that it's been eradicated. We've also worked to suppress polio and measles, and have done a decent job, although some of those are starting to increase in incidence in recent years. The models really depend on the pathogen that you're studying. So how that pathogen impacts humans, what happens to the immune system, how the immune system responds. The first model we're going to talk about is called an SIR model. In an SIR model, people move between 3 states. They can be susceptible to the pathogen, the virus, the bacteria. They can be infected, and once they're infected, they move out of the S group and into the I group, and then they can become resistant. The resistant group either develops immunity, long-term immunity, or sometimes they die, so they don't wind up back in the population, or sometimes they recover and just will not become infected again. In the case of COVID, where you've got this really long latency period between when someone's exposed and infected, you actually can move between 4 separate states. You've got this susceptible and exposed state where you know you've been exposed to the pathogen, but you haven't quite yet been infected before you moved into that infected category, and then the resistant category. It's just a slight twist on the model above, the SIR model. And it's something we use when we're trying to reduce the number of people being exposed, like we were with COVID. To model it, we really think about what happens to drive people in between these various states of susceptible, exposed, infected, and recovered. And we can calculate the probability that someone moves if they, given the fact that they're susceptible, what's the probability that they move into becoming exposed? And we use differential equations, which are a fancy mathematical term that I actually spent more time in engineering school doing than I have in my epidemiology career. But the differential equations really allow us to look at momentary changes. So it really helps us to understand these changes that happen rapidly rather than slowly over time. So what we do, it's if you want to think about it in a very simple way, it's almost like a probability that you move from this one state to the next, where beta 1 is the fraction of people who move on from first being susceptible to then being exposed. Then you've got beta 2, which are the people that are exposed, but then move on to be infected. And then lastly, the people that are infected, but go on to be recovered. When we look at each stage of this SEIR model, we can apply different assumptions to all of these parameters. It's important that we understand the exposure when we're looking at the fraction that become exposed. So you can imagine, I said it was very simple. Beta 1 was just the probability that you move on, but you have to come up with an equation that defines beta 1 as you're creating these models. And to come up with those equations, it really matters how the disease is spread. Is it fecal oral transmission? Is it airborne? Is it bloodborne? Is it fluidborne? How long does the disease live on a surface? So there are lots of factors that have to go into understanding this. We also have to understand how society is working to prevent transmission, given each one of these scenarios. You can see that there are several different ways. If it's a bloodborne disease, we regularly test the blood supply. For COVID, we looked at using face masks to keep people from being exposed. We limited to the number of contacts people had. So there are lots of different ways to try to mitigate, to stop people from being exposed, given that they are susceptible. Now, what about infected? That's actually a whole different set of parameters that we have to look at. So not everyone that's exposed will become infected. There are some diseases where that's not the case. There are diseases where, basically exposure and infection happen simultaneously. But in the case of many infectious diseases, there's this period where you're waiting to see if someone becomes infected. It really depends a lot on the person, the individual person, the dose they get, and whether or not they have any kind of natural immunity to the disease. Then lastly, we have to figure out this fraction that wind up becoming resilient. The goal of a vaccination campaign is to basically bypass this middle path and just shoot people right over to resilient so that they don't wind up having to go through the infectious period. They don't wind up having to risk death. They don't have to risk the side effects that happens when a virus goes into the body and it might eat, like with the SARS-CoV-2, you get that the tissue in the lungs that can be damaged. You get some long-term COVID symptoms. So the goal is to avoid the infection part of it, jump right through and head over to recovered. So basically these models that people build, like I mentioned, the benefit of them is they're highly flexible. You can actually look at different time points and you can make different assumptions and assume that the rate of people moving from susceptible to exposed varies from one time point to the next. It helps you to take into account changes in human behavior, in technological advances to control a disease. And then you're able to build the model and make changes with those assumptions. So basically, we can just put all of that together to build these models that allow us to figure out how many people are susceptible and how many people are infected at each individual time point. And that's basically what the models were doing. All of the models that you've seen for COVID, that they wound up just modeling the number that were infected. They then translated that onto hospitalizations or deaths or other things, but modeling that infected number is the one that really matters. That all assumes that the disease you're studying has an endpoint, that after a person becomes infected, they then go on to be resilient or recovered, but they're not susceptible again. There's a whole nother type of infectious diseases where you don't get long-term immunity, where just because you've had the disease once does not mean that you won't get it again. These models are called SIS. Many parasites follow SIS, and I don't know how many of you out there are in parasitic disease control, but parasites are very, very difficult to control. And that's because there generally is not long-term immunity. So a person gets infected with a parasite, like say a tapeworm, and it winds up in their gut, and they will have some issues with it. They'll actually see it. They'll take the anti-parasitic, the tapeworm will die. And then if they eat contaminated meat or wherever they got the tapeworm from the first time, they're right back to having the parasite again. So parasites often do follow this particular transmission cycle. Interestingly, most coronaviruses follow this transmission cycle too. We had hoped that SARS-CoV-2 would not be like most coronaviruses, that it would provide some kind of long-term immunity the way that measles does, where if you have measles, you're highly unlikely to get measles again, or if you're vaccinated for it, you're unlikely to get it. But it is starting to look more and more like coronavirus, or the SARS-CoV-2 is more like a typical coronavirus, where a person develops immunity to it. It lasts about 6 months, and then you're susceptible again because your immunity kind of fades back down a little bit. This is very common for seasonal colds. It's not just coronaviruses, other seasonal colds too, RSV, the things that would typically make you a little bit under the weather, but not knocked out the way influenza or SARS-CoV-2 did. So that's one of the things about this particular coronavirus, why I think you're starting to see some of the models that early on predicted this would go away and be gone. It doesn't look like those are going to hold, because it does appear to be following this SIS transmission pattern. So what do we do with SIS? Well, the key is to stop the transmission cycle with these SIS diseases. When you know someone can go right back to being infected again after you've cured them. With the parasites, you try to eliminate the parasites. When it's in, say, meat, you work on teaching people about cooking practices and the importance of getting the meat high enough, proper handling of the meat. If the parasite's living in water, as often is the case, you work through the proper authorities to try to eliminate the parasite from the water. if people are swimming in it or if they're drinking it. Could be well water. There are lots of different ways that parasites get into the human body. So you want to break that transmission cycle wherever the parasite is occurring, or the pathogen, if we're talking about a virus. When you're looking at a virus like coronavirus, like rotavirus, that daycares and childcare centers often go through these rotavirus seasonal trends where you'll have a big outbreak and you've got to kind of close down for 24 hours and really disinfect all of the surfaces, disinfect the bathrooms. Rotaviruses are incredibly hard to break that transmission cycle. You got to get everything really cleaned down. But that's the key with these SIS viruses, pathogens, sorry, because it could be parasite, could be bacteria, could be anything. That key is to stop transmission, to at the environmental level, try to make a change so people don't become infected. So the third thing we can do is take a look at kind of fitting the data we have to our current outbreak. And that's a lot of what I did with SARS-CoV-2 as it was coming down the pipe. This allows you to model at the local level, which is when you learn Epi 101, one of the things you learn is you really want to model at the local level to predict what's going to happen next, because what's happening here may not be the same thing that's happening in, say, India or Europe. The strength of using real-time data to inform what's happening locally is that you actually get it tailored to the local population. It takes into account local behaviors, local dynamics, things that might influence disease spread. It becomes easy to visualize and it's really easy to understand. The differential equations I showed for the models before, those are very difficult to understand. They're even more difficult to properly put your assumptions together. As I showed you from each of those stages, you have to make some pretty big assumptions about the disease and the disease process and the virus and the virus dynamics. So Model 3 allows you to use more learning from what's going on at the local level. It has limitations though, big limitations. Model 3 relies on testing, so it assumes that you actually have all cases in the population accounted for. It assumes steady state transmission dynamics, so that means that that you get a very steady state of infected and then kind of coming back down the other side. It does not take into account any kind of interventions that might occur. So masking, if you were to shut down that, let's say we're talking about a rotavirus outbreak, and you were to shut down that daycare or that school that we're having an outbreak and really sanitize it and then bring people back, it wouldn't take that into account. It also does not take into account mobile populations. So let's take, for example, I'm from Michigan, and one of the common things that happened in Michigan was that older folks would head down to the south. The snowbirds, as we used to call them, they'd head down to the south and then they'd come back. And it doesn't take into account those regular moving populations where you might get an influx of new folks and then those folks might leave. So a model like this would not take that into account. The population for this model really is very important. It's important that you know if you're talking about the county level, the city level, maybe the hospital level. Again, it depends on that pathogen. If you're looking at Legionnaires and some type of Legionnaires outbreak, you're probably talking about a building, one contained building. So knowing who the denominator is that you're looking at is very important for this model. The other thing that you have to be thinking about is the R0. R0 is used at the very beginning of an outbreak to determine how quickly a disease races through a population. You can think of it in terms of how infectious the disease is, how rapidly it spreads. It basically corresponds to the number of people that are infected in any given cycle. So if the first tier people at time 0 were infected and each one of them infected 3 people at time point 2 or time point 1, then you're looking at an R0 of roughly 3. We're still figuring out the R0 for COVID. It continues to evolve, but it looks like it's somewhere between 1.2 and 4. There are a few places that have estimated it as high as 10 in populations where behaviors might have been more conducive to spreading it in, say, young people. And to compare that to one of the most rapidly spreading diseases we know, that's measles, which is has an R0 closer to 18. There's so many models you can use. You can take a look at these websites. CDC is now doing a really great job of basically bringing all of the models together and then trying to create an average, if you want to call it an average model of what's going to happen in various areas. So if you have time and you want to go check that out, they're doing quite a bit to help model with COVID. They do this for other infectious diseases as well, as we wind up with outbreaks for different infectious diseases. So in terms of what we do with COVID, it's really important that we know the assumptions in any model. And to give you a feel for the original paper that modeled COVID, that's where we got a lot of our guidance from. That paper assumed that no one in the population had any kind of immunity to this particular virus whatsoever, that it took on average 5 days from the time a person's exposed until they became infectious. But they assumed that the infectious period was about 12 hours prior to the first set of symptoms. They assumed that symptomatic individuals were more infectious than asymptomatic individuals, and they looked at an R0 of about 2.5, which is still within the range of where we think it is. So when we think about those types of assumptions, that there are a couple of them that may be the hardest to prove. For example, proving the asymptomatic transmission, we still don't have great data on asymptomatic transmission. As an epidemiologist, that is hard to study, though. To find people that are asymptomatic and infectious, that's needle in a haystack stuff. You'd need a huge grant, millions and millions of dollars to find those folks. These were the models that, as we talked about flattening the curve and using that common vocabulary, the early models really gave us that vocabulary for SARS-CoV-2, because the folks at the Imperial College created various scenarios where if certain behaviors were taken, it could lessen the impact of COVID on the population. So what about the real-time monitoring that I mentioned before? There's so much data available. I'm going to do an Alabama specific example and run through this before we get to the end of it. And hopefully y'all will have some questions at that point in time. How do you even know what to model when you've got people with, case positivity rate data, and you've got folks doing different types of testing? Some people are only getting tested if they're symptomatic. Some people are getting tested 3 times a week just so they can do their job. How do you think about cases? Do you use all the cases? Do you use daily cases? Maybe use hospitalizations? And we'll kind of go through each of those here in a second. In terms of case positivity, we still use this as a metric, and CDC actually doubled down on it early this year in the summertime to say that case positivity is a really important metric. As an epidemiologist, I don't love case positivity as the metric you use, because at least in a state like Alabama, where we don't do widespread for-cause case contact testing, asymptomatic testing, it's really tough to understand what case positivity tells you besides the fact that cases are going up. Because case positivity, remember, is going to be the total number of cases divided by the total number of people tested. And if the people tested are only going out because they're having symptoms, that's a very different type of denominator than if you were able to test everybody. An example of case positivity where you're really kind of doing more of 100% testing would be, and probably not 100% because that would get expensive, but in the meat packing industry, they're going to do much more regular testing of what they're putting out the door to ensure that they're not putting out contaminated meat. So their case positivity rate means something because you've got consistent and regular testing and a protocol that's very standardized. So this is what I was talking about with how messy the cases can be. This is what the epidemic looked like here in Alabama over the past several months with these 3 distinct peaks for SARS-CoV-2. The deaths are even more erratic. When we start looking at deaths, you see them really kind of peaking and coming back down after the initial peaks related to the cases. And the interesting thing about deaths is that deaths are very hard to process. In general, in epidemiology, we don't want to use deaths as our marker for how bad the epidemic is. Deaths take time. The medical examiner has to look at the death certificate or look at the cause of death and determine what that cause of death was. That has to be filed. And then that has to be, combed for data. That takes time. We can be up to 3 or 4 weeks delayed. And you can see when you look at the actual date of death versus the one that I showed you a second ago, you actually see slightly different peaks that are a hair smoother than what we saw the last time. And that's just because the actual date of death is often quite different than when the paperwork is filed. We also see big differences by age groups. That's why I always would say, think about your denominator when cases are increasing and you have to decide whether it matters. In the particular case of SARS-CoV-2, this one has been interesting because we saw these unique peaks related to young people. About a year and a half or 13, 14 months ago, we saw universities start back up, and there was a big peak in 18 to 27-year-olds that happened when universities started back up that stayed pretty much isolated to the universities. You don't see any other age groups popping up right after that. And then quite recently, the outbreak we're in the middle of, kind of coming back down the other side at the moment, we're seeing this big peak in 0 to 17-year-olds. So when schools started back up again in August, we see this big peak with the 0 to 17-year-olds. In fact, it's higher than any other age group has experienced throughout the pandemic. These are data we might use for modeling to think about, okay, how does that change the way it would move through the population? So it becomes important to know these data by age. We also want to translate these into hospitalizations because, again, in the case of SARS-CoV-2, we're very worried about the number of people that wind up in the hospital because that can influence the hospital's ability to manage large numbers of cases. So how can we forecast those hospitalizations? CDC, like I said, they're doing a lot of estimation of hospitalizations, but at least in Alabama, one of the things that I found to be the most helpful is to look at the cases 14 days prior and try to estimate where the hospitalizations will go from there. This third peak that we've hit, the one that started in July, the data started to become concerning right around the 4th of July. The blue line is Mobile County. And as we were watching the data, Mobile just really spiked very rapidly. You know, in about 2 weeks, it went from pretty low case levels to off the chart case levels, much higher than we'd seen in the past. So as we use that data to try to figure out what would happen if every single county in Alabama had the same level of spike that Mobile did, I worked with the team and we put together 3 different models. We looked at the Alabama rate. What if everybody in Alabama followed this number of cases? What if we followed a rate more like India, in terms of India and the Delta variant of SARS-CoV-2, where would our cases peak? And what if we were more like the UK that also experienced a Delta outbreak, but it was much lower because they had already had the vaccine available? So kind of taking a look at all 3 different curves to try to get a feel for how bad it could be. And this started in about mid-July. The important thing with this particular outbreak, again, as you're communicating with your partners and understanding the impact to you, is to think about what those numbers mean. And so from each of those 3 models, we could see what the peak daily cases would be. If we hit that Southern Alabama rate, we would have been looking at 13,000 cases per day, which would be off the charts. We did not hit that. It's just for folks to know. And that would have corresponded to 8,000 hospitalizations, which is really, really high. On the other hand, with India, which was kind of a lower rate, we would have hit about 7,000 cases a day and hit a peak hospitalization of 4,200. And then the UK rate, we would have peaked at about 4,000 with 2,300 peak hospitalizations. So each one of these had a very different estimate. The other thing that's interesting in looking at these is thinking about how many people are sick, because hospitalizations matter to the hospitals and matter to all of us. That's important. But what else matters to us is our ability to live our daily lives, to go to school, to get coffee at the coffee shop, to do the things we normally do. And what was interesting about this particular outbreak was if we would have hit those levels, there would have been 4% of the population out actively sick with COVID at that peak. That's a lot. 4% may not seem like a lot, but that's a lot of people that are unable to go to work, particularly because with COVID, for every person that comes in contact with one of those sick people, they then have to quarantine. So if we count quarantine too, it would have been roughly 1/5 of the population out. And we did see there were a couple of weeks where it got really high and lots of folks were out. But again, we're now starting to come down the other side a little bit. And Elena, feel free. I just noticed that there was a Q&A. If you need to break in and ask any questions, feel free to do that.
Yeah, I'm going to go ahead and break in now because the question is relevant to what you just talked about.
Okay.
So a viewer wanted to know if you thought that the peak in Mobile was due to people traveling to the coast during summer vacations.
Yeah, that's a really great question. I think that likely that was the case because we saw a very similar peak occurring on the Florida beaches. It wasn't unique to Alabama, and also all the way over to Mississippi Gulf Coast and Louisiana. So this really did seem to be a very consistent pattern that started after the 4th of July, and probably was people coming down, having some vacation, and then heading out. Interestingly, at the exact same time this was happening, Las Vegas had a very high outbreak as well, and so did Missouri. Missouri has a large recreational area called Lake of the Ozarks. So, people had been locked up, really quarantined for about a year. And it's quite possible that that's when people started feeling comfortable getting out of their houses. They did some vacationing, perhaps had behaviors that were a little less safe than what they were doing at home during their quarantine behaviors. I think that's a very likely explanation as to what could have been going on. But unfortunately, I think it, I can't prove it. So now where we are, in case some of you were wondering, with the current hospitalizations in Alabama, the dashed line does not look like a dashed line in this figure, but this line way over here to the right are actually estimated hospitalizations for the next 6 weeks, what we expect hospitalizations to do as we kind of keep coming through this Delta surge. We are seeing steady decreases week over week over week, with about a 2 to 3% decrease in cases each week, and then corresponding decrease in hospitalizations. The last thing that I get asked about a lot is herd immunity. And what is are we going to have herd immunity? When will we have it? I think the real question is, when is this SARS-CoV-2 going away, so I don't have to think about it anymore? We're going to go back to that R0 number I was telling you about. This is a map of various R0s for SARS-CoV-2 that have been calculated in the United States. They range between basically 1 and 13. Why it matters is that R0 can provide a really simple way to calculate herd immunity. If you've got a virus that spreads really quickly, you have to have much higher levels of immunity in the population. So you can see how this plays out. In New York City, they estimate the R0 was closer to 10. That's probably because it's dense. There are lots of folks living together. They're more likely to come in contact with each other, and that's just going to lead to more rapid spread. Well, when you've got an R0 that's that high, you really need to get immunity levels up closer to 90%, which is what we need for measles. That's why we consider a successful measles vaccination campaign to be at least 90% of the population vaccinated. That helps to keep the spread of measles down. What actually happens with herd immunity, what we would see if we had herd immunity would be that cases would decline without social intervention. So you'd see people out and about. There would be no masks. There would be people in tight bars and talking loudly, and cases would still continue to decrease. And that would be because enough people had immunity that it wouldn't spread from one person to the next. Even with herd immunity, we would have isolated outbreaks. There would be communities that perhaps had low vaccination rates or lower levels of immunity. Maybe their immunity was starting to wane. You would have these isolated outbreaks. But the difference between herd immunity and no immunity is that those outbreaks could be contained at that local level and wouldn't spread out to the rest of the nation. You may even see the virulence of the virus decrease. That's, I think, what we're seeing right now. We're seeing that in folks that are vaccinated, they're less likely to go to the hospital. So they might get an infection, but they don't wind up in the hospital. And that's actually a win in public health. That's what we usually hope for with a good flu vaccine. It's not so much that it is a guarantee you won't get the flu, but at least you don't go to the hospital. We have to continue to monitor all viral mutations, which is what the epidemiologists do anyways. They look for these viral mutations to see if something changes in a virus or a bacteria that requires vaccination updates or a change in strategy. Those of you that are interested, you can track all of this. The World Health Organization releases regular outbreak reports. So does CDC. If you're an epidemiologist like me and you have fun reading that data and it doesn't keep you awake at night, it's just interesting to see what things are circulating. We'll continue to do surveillance. We'll look through sentinel surveillance, which sentinel surveillance means we use very specific places, cities like Chicago, Los Angeles, where we'll do some more aggressive testing of folks. We can do seroprevalence. The blood supply can be tested to look for antibodies, also lab samples, regular lab samples. And then CDC will come up with networks, which they already have for COVIDnet, FluNet, to try to get a handle on how many cases are out there in the community. This is going to be my last slide, and then I'd love to take some questions. How do we use the data that we have for future outbreaks in our center? I think the key is for us, those of you that may have outbreaks that you're dealing with and you reach out to the center, the number one thing is the pathogen. We have to know what the pathogen is so that we can identify how it's spread, how we might want to model it, how severe it is. The severity will determine the types of actions that need to be taken. And then how do we communicate practical measures to reduce the transmission? That's what people are looking for at the end of the day, because the public and public health, I like to say this a lot now, means people getting together. I mean, that's what we want with good public health. We want people to get together, and we want them to be able to do that safely. So being able to communicate those practical measures so that society can continue to behave in a social way while remaining healthy, that's that public and the health part, is our number one goal. And with that, Elena, I'd love to hear the questions.
Yes, and there's been a few questions that have come in. Thank you so much, Dr. Judd. That was a great presentation, very relevant, very important information. So the first question we have is, what are the various tests for COVID-19 and what are their sensitivity and specificity?
Wow, we could do a whole lecture on that. There are many different tests you'll hear about. You'll hear about antigen, you'll hear about PCR, and then you'll hear about antibody. The antigen and PCR tests are basically indicate whether you're infected right now and potentially infectious. That's where, if they're doing the PCR, that's actually looking for viral DNA. So looking to see that there are pieces of the virus's DNA that can, the virus can continue to replicate. The antigen test is looking for a piece of viral protein. So it's looking to see if that piece of the outer shell is there. Which does not necessarily mean that the virus is replicating, but it means you've got pieces of the virus in your body, or in your nose, usually is where people are testing. Although people also test saliva and other parts of the body. The antibody test is actually looking at whether or not your body has at some point in time fought SARS-CoV-2 and now has antibodies to it. They can tell if you do an antibody test whether you've got antibodies to the vaccine or the infection. So you can actually look at different types of antibodies. The antibody test does not tell you whether or not you're safe from future infection, because you can have antibodies and still wind up infected at the future with SARS-CoV-2. So there's several different tests. The sensitivity, the false positive rate, and false negative rate, and specificity or false positive rate varies widely within all of those tests. It depends on the manufacturer. It depends on what they're testing, depends on where the sample's collected. So there's not a one size fits all answer as to which is most sensitive and which is most specific. And it also depends on whether or not you're symptomatic. So there are lots of factors that go into that. If you're looking for a test in general, there are some good antigen and PCR tests on the market. The PCR is generally considered to be a better indication of whether or not you're actually infectious.
Thank you. We have another question. Are you comfortable in saying that we have passed our peak for the current surge? And if so, how? Why? And I know that may be a difficult question to answer.
I love it. I love it. I love a loaded question. Yes, if you would have seen me 2 weeks ago, I was being a little less comfortable saying that, but we're seeing week after week after week now, 3 weeks of sustained decrease in cases, which from a data standpoint, that makes it highly likely that we've made it past the peak. Personally, yes, I think I'm getting more comfortable. The issue is we're not there yet. So we've got to get us down to less than 1,000 hospitalizations. We really want to hit less than 100 cases per 100,000 per week. We're almost there. We're probably going to hit both of those in early November, if all goes well. And once we hit those two things, where we've got less than 1,000 hospitalizations and less than 100 cases per 100,000, that's when you can really kind of say, okay, now I can be a little more comfortable, maybe a little bit more lax, but keep watching the data. I think one thing we're learning about this particular virus is it looks like your immunity may wane, so that you may need boosters. The cases may continue to kind of go down and come back up with a fourth or fifth wave. So keep watching the data, but yeah, this particular peak does seem like we've come down. We're on the downward slide.
That is very good news. And speaking of loaded questions, this one kind of has two parts and I'm going to tack on a third. But has modeling shown any trends that align with prior infectious diseases? And what about COVID has modeling shown to been unique or to be unique? And I'm going to throw another one was what can we learn from this COVID-19 pandemic, the modeling for future infectious disease outbreaks?
Yeah, that's great. So yes, the modeling for the first question, has it shown to be to the models fit with previous infectious diseases? Absolutely, but not the ones we had hoped for. We had hoped when we created the models that the models would fit where once you're recovered, you don't wind up susceptible again. So if we compare this particular SARS-CoV-2 to normal coronaviruses or RSV, patterns we would see in RSV, then yes, these models line up almost exactly with what we would expect to see. We had hoped that it would not be that. We had hoped that it would be something where you'd wind up recovered and not susceptible to the virus again. So it wouldn't be this kind of seasonal cycling that we see with influenza, with other coronaviruses. What's been unique with this one is the asymptomatic rate. This is a tough one. I'll be honest with you, as an epidemiologist, asymptomatic infections are so difficult to manage. What do you do if someone's not showing symptoms? Our best way to identify who is unwell is for symptomatic infections. So that was the most thing that was unique. And Elena, what was your third part?
If there's anything that we could learn from this COVID-19 pandemic that we can apply to future outbreaks.
Absolutely. I think communication. I think that the thing we learned from this one is how we communicate with people, that we have to keep our communications very simple and be sensitive to what their concerns might be. I think one of the things we have to start letting people know is that COVID probably will cycle. It probably will go up and down. And the key will be watching the hospitalizations to try to see, what's happening. Are people winding up in the hospital? Is it behaving the way it did in the past? So having really good, solid communications, that's what we learned on this one.
Couple more questions. Are there any studies to find out the level of antibodies that is protective against COVID? When would you know how to get a booster? When would you know to get a booster?
Oh, I know, really good questions. Not great studies yet to know what that threshold is on antibodies, but those will come. Give the virologists and the immunologists about 12 to 15 more months, and they'll have a really good idea of what that threshold is. But no, they don't have it yet. In terms of a booster, there's some great guidance on the UABE reporter that came out this week, and also that CDC has put out about when you need a booster. It depends on your age. It depends on whether or not you're immunocompromised, whether or not you're caring for people that are immunocompromised. And then you'll have to just make a gut level decision for yourself, just to be, personal. So you can see that I too know exactly what you're going through. In my case, I'm thinking that I probably need a booster toward the end of this year. I have an aunt that is immunocompromised, and I want to make sure I get my booster before I see her. But it's tough. There's not a ton of evidence yet to know, does it differ by which vaccine you had? There's some evidence maybe it does. But I think in general, just for safety's sake, that's where you can err. You can take a look at the CDC's guidance and see which age group you fall into and whether or not you're going to be around people that are immunocompromised.
Great information. And any thoughts about other variants? Are one more or less transmissible than Delta? Cause more or less illness? Can those cause more or less illness?
Absolutely. There are so many variants out there, and some of them do cause more illness and escape the vaccine. So they are more problematic. We're watching it to see if they wind up being infectious. You can get a variant that is pretty dangerous, but doesn't wind up spreading. And so far, the variants that are out there are not spreading rapidly the way Delta did. So that's one to keep watching. But right now, it looks like once we make it through Delta, there's not one coming right on the heels of it.
And if COVID does become endemic within the US, are models used to predict the spread of those infectious disease similar to what you just shared with us, or how are they different?
They are. If it becomes endemic, the models are almost exactly the same, and they're very similar to what we use to model flu.
And then what are some of the challenges? What have been some of the biggest challenges in modeling the COVID-19 pandemic? And I think you touched on them a little bit, but if you could share any more information about the biggest challenges in modeling this current pandemic.
Yeah, absolutely. The information changing, that was the biggest thing in the beginning. We didn't know exactly how it was spread, and we were getting different communications, even from scientific publications. Was it airborne? Was it not airborne? Could it live on packages? You may remember early on, there was confusion about whether or not it could live on a package, on something you picked up at the grocery store. So that was challenging until we understood the COVID-19 itself and how stable it was in the environment after it leaves an infected person's body. Then that asymptomatic piece, I'm telling you, still with that one, the fact that 50% of the people that wind up infected can be totally asymptomatic, that is really, really challenging to model. Because the reason for me it's challenging is, how do we know it's 50%? How do you model something you don't even know? Undiagnosed COVID, how in the world do you begin to model that? So that's another really tough piece, is that asymptomatic rate. I would love to have better data on the when someone was infected, was at a lower viral load? Is there something unique to that person as to why they didn't develop symptoms and a full-blown infection? Those have been some of the really big challenges with modeling.
And I think we have time for one more question. This will be our last question. But what are some of the ways you think communication could improve in the future?
So I think that it's really important that we, especially as scientists and public health professionals, I think we avoid using our typical words that we use. Susceptible, for example, the word that I've been using all day. I don't know that I would use that if I were communicating with the public. I think we have to be really intentional about the words we choose, and how we explain it. And also very clear that sometimes we don't know, that we're still working through this. We need, and be really honest about how long it's going to take. We need about a year to get data on that question. Until then, here's what we need to do. So I think that the more we can communicate with the public with words that they've heard in the past, so that they know what they mean, and then with true, honesty and empathy for what they're going through, I think that will help us.
All right, and I think that is time for our webinar. Thank you guys so much for joining in our webinar. And Dr. Judd, thank you so much for the information you presented. It was excellent and timely, and hopefully something that everyone can kind of take back to their institution and learn from. Thank you very much.
Thank you for having me.